Chapter 19, Non-Aseptic Techniques. As with every part of patient care, having compassion and caring, as well as being technically competent, are equally important. The procedures in this section require all of these things. You need to be aware of the patient's dignity and privacy as much as possible in these procedures. As you can imagine, they're very self-conscious and uncomfortable, needing help with all of these things. So just keep that in mind, how you would feel or how you would want someone to treat your grandmother or things like that. Just keep that in mind. You have to be confident as well as informative when you're explaining procedures to your patients, and you need to be compassionate to their discomfort. And sometimes even in just discussing it, there are probably people who you have to tell them about these procedures and they don't even want to talk about it. They don't want to know about it. They don't want to think about it, but you're still going to have to explain things to them so that they understand and you can get their consent and cooperation. Non-aseptic techniques are a clean environment, but not a sterile environment. These procedures are usually of the digestive tract, and with the exception of the NG tube, most often they're performed in the fluoro room in the radiology department. Your history taking and procedure explanations are really critical in these examinations. If you don't explain it clearly, then patients aren't going to understand what to expect. And you don't want them to be surprised when you go to put a tip in their rectum and they didn't know you were going to do that. So you have to be clear in your explanations and straightforward to make sure they understand. Look them in the eye and make sure they understand what you're saying to them. NG tube placements most often happen in the patient's room. After the tube is inserted by a nurse or a doctor, they have ways to tell if they're in the stomach or not. But they also can call for x-ray to check, either a portable or with the C-arm under fluoro. Lumens, the most common NG tube is a Levin tube, and it has a single or double lumen. And lumens are one or two distinct tubes at the distal portion of the NG tube. The advantage of this extra tube is that it's smaller, open end is open to room air, and it allows for equalization of pressure in the stomach so that when the suction is turned on continuously, it's not going to suck the edges of the stomach and the mucosal lining of the stomach up to the tube that would block it and also damage the lining of the stomach. So the air pressure change just allows, it's like a Ziploc bag. When you close it really tightly with no air in it, the sides stick together. But if you have a little bit of an air vent, it can be closed, but it allows a little air and the sides won't stick together. Kind of like that. I mean, that's a weird analogy, but it gets the point across. So that extra tube is just to allow some air for equalization of pressure so that the tube won't stick to the stomach lining. You have to be careful not to accidentally pull the tube out. As with anything, when you're doing portables in a patient's room or working around a patient that has a lot of tubes and wires and all that. You guys won't ever insert an NG tube, but a doctor or nurse certainly would. Patients need to, and the procedure needs to be explained to them, and they need to get consent. And the patient is in a high Fowler position. So a Fowler position is sitting up or upright in the bed. So they want you in a high Fowler position, which is as close to 90 degrees as possible. As far as measuring for the distance from the nose to the stomach, you measure the tip of the NG tube where the lumens are, and from the nose to the earlobe, and then from the earlobe down to the xiphoid process. The Levin tube also has markings on it, so when you get that measurement, you can mark with a piece of tape or something where the tube, how far the tube gets inserted by the marking on the leaven tube, so you don't push the tube in too far or not get it in far enough. You need to use a lot of lubricant on the tip so that it goes in smoothly and through the nares and through the nasal cavity. Instruct the patient to swallow. I think the things that I've seen show the patients drinking water out of a straw, or just even sucking air in through a straw will help them swallow. They don't ever force it down, because you don't want to tear anything. The lining of the esophagus is just as sensitive as any other mucosal lining. So then after they get the tube in place, you would take a chest x-ray, likely toward the lower end. You need to make sure that you increase your technique to make sure you penetrate well to visualize the tube in the stomach. Let's see. The other way they check it is to they use their stethoscope and listen for a whooshing sound when they inject a little air into the air tube of the 11 NG tube, to make sure they're right in the stomach where they should be. But then, x-ray, of course, if they're not sure. Transporting the patient with an NG tube. Most hospitals have transporters now, so while you may not have to actually transport a patient with an NG tube, you need to know what to do with them when the patient gets to you. On page 247, there's a step-by-step guide as to how to disconnect the suction safely for transporting the patient. There must be a doctor's order to disconnect the suction, or you shouldn't be doing it. So confirm that there's an order from the nurse and allowing the transfer and the interruption of suction. You need to know how the suction device in your departments work, or if it's a portable suction device, or if it's connected to the wall, if you have suction in your room, your exam room. Those are the things you need to know before the patient comes down, so you know how to hook them up properly. You need to understand how to set the suction pressure gauge per the doctor's order, or ask the nurse what needs to be done, how it needs to be set if the nurse doesn't come down with the patient. That way, then after that, you turn the suction on and reattach the tubing so that the patient is having their suction as they need it. Special considerations for the double lumen NG tube. The NG tube, the double lumen, one of them is the tube into the stomach, and the other one is a little air vent that we were just talking about. If you clamp the air vent, as it says to clamp the NG tube for transport when it's a single lumen, if you clamp the double lumen air vent, sometimes that damages it so that it won't allow air to vent in as it's supposed to. Typically, there's going to be an anti-reflux valve that should be used on the air vent side, and when you disconnect from the suction, you can loop that around and connect the other end of the anti-reflux valve into the clear tube, the part of the tube that was disconnected from the suction. So you make it into a loop so it's all connected, and then you use a safety pin and attach it to the upper part of the patient's gown so it's above the stomach so that it doesn't leak out. If there is no valve, the anti-reflux valve, then you can also use just a small syringe and block the opening, but you have to ensure that it's attached to the patient's gown up above the stomach. Otherwise, gravity will cause siphoning of the contents of the stomach, and then you'll have a mess. So just be careful not to clamp the air tube so you don't damage it, and make sure that the NG tube is attached to the upper part of the gown on the patient above the stomach so you don't have a leaking issue. You will have on occasion to do an upper GI or small bowel series on a patient with an NG tube. Of course, they won't be drinking the barium. You're going to have to inject it through the syringe into the stomach. So you'll learn about these procedures in the next year or so. But for now, learning how to handle the NG tube correctly and in a clean manner will be a good starting point for you. So you're not going to typically remove the NG tube either. That will be something, it's good to know, but you're not going to have to do it. That's not going to be part of your job. Always put on your clean gloves. Page 246 in your patient care book has a description of how to remove the NG tube correctly. Anytime you have resistance with withdrawing the tube, stop what you're doing and have someone else help you with it, a supervisor or nurse or the radiologist, someone who can manage that, because you don't want to hurt the patient. Urinals. One of the first things you need to do in your department is find out where they keep the urinals in the bedpans. You don't want to be in a situation where a patient needs one and they need it right now and you don't know where to find them. So find out ahead of time now. Go into your department and find out where they keep the urinals and the bedpans, just in case you need them. Try to give the patients privacy whenever you can as well, if they're able to manage the urinal on their own. So typically urinals are disposable, not so much reusable anymore, but I guess there are probably some out there. The male urinal is shaped to be used sitting or lying down, so most men can manage it on their own. Sometimes you'll need to help them, but do your best to give them as much privacy as you can. Sometimes you need to find out how much urine output there was, and keep track of that for the nurses. They may be tracking it for documenting it for a purpose, so you need to make sure that you document the volume of the urine before you dispose of it. Wash your hands. Help the patient wash their hands when they're finished. Bedpans. There are two different types of bedpans. There's a standard bedpan, and then there's a fracture bedpan. And the fracture bedpan is for patients who might not be able to lift their hips high enough or roll onto the standard bedpan. The standard bedpan is a couple inches high, and it's I would guess a little tough to get up onto. And particularly if you have a broken hip, you're not going to lift yourself like that at all. So it's a little lower profile, and it can slide under the patient with a little bit less discomfort. Once again, once you get them settled, if it's possible for you to leave the room and give them some privacy, that might be a good way to go. Make sure that they're safe, and don't leave them for too long, because they might need some help. Be within calling distance of the patient. You can see here how the fracture bedpan can slide in under the patient. So just for perspective, because if you've never used one of these before, so it might be a little bit confusing. So the very thin edge of the bedpan goes towards the patient's back, and the thicker wedge end is toward the patient's legs. If you don't get it right, the patient will be super awkward, and you will have a mess on your hands, maybe even literally. Patients may require help cleaning after they use the bedpan, so always be cognizant of their dignity. When you be sure to wipe the patient, the perineum, very clean and dry. And for women, you need to wipe front to back in order not to contaminate the genital area with feces or anything else. You have to be really careful with that. Always dispose of it after the fact in a biohazard receptacle. Enemas. Enemas are exams of the colon that require it to be very, very clean of fecal matter. We're looking at the lining of the bowel. So if there's any feces in there, any waste of any kind in there, it's very difficult to see what they need to see in the exam. The procedures could be contrast enemas with barium or with gastrographin, or virtual colonoscopy and CT, or colonoscopy or sigmoidoscopy performed by gastroenterologists. These are all things that they're going to look at the colon. The colon needs to be really clean. The preps usually take a couple of days, and they are really good at making sure the patient is really cleaned out. They need to have an understanding, though, how important it is to use the prep and do it properly so they do get cleaned out well. Inpatients may require cleansing enemas before they come to radiology. In the book it says the tech may have to do that, but I don't know if you actually, I've never done one, and I don't know if they do them now, cleansing enemas in the department. I guess it's possible. Ask in your departments if they end up doing them. Typically, if they're inpatients, the nurses try to prep them before they come down. So it is very much to your benefit, though, to know the prep requirements for the contrast enemas so you can talk to your patients about it. So these are the different types of cleansing enemas. The pages 350 to 352 have very good outlines of how to administer a cleansing enema. There's a good explanation of how to insert the tip for the enemas as well. So on pages 252 and 253, there are inpatient and outpatient preparation examples. Please read those and understand those. They will be on your quizzes and your final exam. Patients will always tell you that the prep is the worst part. They likely haven't eaten for a couple of days other than clear liquids, and during the purging period they may not have slept very well either. So be sure to keep an eye out for your patient having difficulties because they haven't eaten for a couple of days. They will have had low residue diet, clear liquids, laxatives, and possible cleansing enemas. And like I said, patients need to understand the prep instructions really well so that they're cleaned out and the radiologist can see what they need to see. There are a lot of reasons to perform a contrast enema: diverticular disease, inflammatory bowel diseases, colon cancer screenings. Sometimes a colonoscopy is done, but they can't get to the distal part of the colon, so the patients will come in and have the distal portion looked at. Sometimes there are questionable findings on a CT scan, or the distal intestines have some kind of an obstruction. So there's, even though no one likes barium enemas and they keep thinking they're going to go away because CT is really good, there are still instances where barium enemas are the best way to see the colon. Barium is most commonly used to look at the GI tract from the top to the bottom, so from your mouth to your rectum, all the way through. They use barium. It's radiopaque and it is not absorbed by the body, so it's a very inert material, so that it doesn't do anything to the body itself except go right through. Water-soluble iodine is the only thing you can use if there's a suspected perforation, and usually that is gastrographin. You never want to use barium if there's a possibility of surgery based on the enema findings. The barium can cause impaction issues or get free into the peritoneal cavity, so you don't want to have any issues with barium being in the abdominal cavity because there's a perforation in the bowel. There are a couple different types of tips that they can use for barium enemas. From experience, I can tell you that the tips without a balloon are really hard on the patient and don't end well in their ability to keep the barium in for the whole exam. You will need to use them on patients who have narrow rectums or have had trauma. You need to be really careful that the balloon is inflated properly. Some radiologists will inflate the balloon under fluoro to ensure that it's inserted correctly. And inserting the tip correctly makes the patient less uncomfortable, and there is less possibility of damaging the rectum or the mucosal lining of the rectum. You must explain to the patient what you'll be doing, and some patients will prefer to put the tip in themselves, which is fine, and then you just check to make sure it's there properly. Most times you can expect that you'll have to do it for them. You really lubricate the tip well so that it goes into the anus easily. And patients who should be laying on their left side with their knees bent or in the Sims position, which is LAO position. Cover the patient the best you can, you know, to keep their dignity to as much as possible. Tell the patient to take slow, deep breaths and try to relax their muscles as best they can. And when you put the tip in, you angle it anteriorly and don't insert it any more than 3 to 4 inches. You'll cover them up again after that and then move them into the position the radiologist prefers to start the enema. In some cases that's going to be prone, in other cases it's going to be supine, and some doctors like to start lateral. So it just depends on your radiologist and getting the patient in the right position. Most hospitals are now latex free, but there are still some tips made of latex, so you need to be sure and ask patients about a potential allergy. The barium is run into the patient from the rectum to the cecum, and I have to say it's not an urban legend that tips have been inserted into the wrong orifice in women. The patient doesn't say anything, and everyone discovers it when the rad tells you to turn on the barium. Want to get away? Barium thickness is important. It needs to flow fairly rapidly, but not so fast that the patient's colon begins to spasm. The powder barium can come already in a bag that you just need to add warm water to for mixing. The bag has a little red ball at the top of the tube, at the bottom of the bag, that seals the end so you can mix the barium really well. And when the bag is all mixed up with the water, then you can pinch on the tube until the little red ball releases out of the tube, and then the ball just floats to the top of the barium. And that way you'll be able to fill the tube with barium and clamp it off, and it'll be ready for the patient. You put the tip on the end of the tube and you're ready for the patient to come in. So you can get this in our prepared packaging like I was talking about, or the radiologist may like to mix it themselves. They may like a specific consistency. You're going to use a thinner barium when you're doing a single contrast, and you'll use a thicker barium if you're doing an air contrast enema. So this is how we used to hang the bag. So you get your bag all prepped. You fill the tube with the barium, and then you clamp it off. There's a clamp right here. And you put your puffer balls on here. One is for air and the other one is for the balloon. So you hang it up on the IV stand ready for the patient. And this is kind of what the room will look like set up. And the radiologist, you will stand and control the barium as they tell you to turn it on and off. For double contrast enemas, it's especially effective in seeing the lining or mucosa and polyps of the colon. If a patient has a history of rectal bleeding, you'll likely perform a double contrast enema. The barium, as I said, for a contrast enema or a double contrast enema is much thicker and has much less volume. The decision of which type of enema is usually determined by certain patient symptoms, patient mobility, or patient history. The ordering physician may decide on which type of enema, but most times it's the radiologist making that decision once the history is taken from the patient. So when you're looking at your double contrast enema, the barium, of course, is white because it's very dense, and the air is black because it's air. The x-rays go right through it. And it's really quite amazing how it looks all with the colon all expanded and the line and lined with barium. It's really amazing looking. So when the patient, so for this exam, the patient starts prone and slightly head down. That helps the barium. You use gravity and help the barium get through the system as you need it, because it's going retrograde, it's going backwards. The patient needs to roll around a bit more to coat the colon, and once the radiologist is satisfied that there's enough barium in there to get it to coat the whole colon, then you'll pump the air in at his direction. And they'll take images as they go. Single contrast enemas, after you've taken overhead images, if the radiologist wants them, then you'll lower the bag to the floor so that most of the barium can evacuate back out into the bag before you remove the tip to get the patient up. It'll be a lot more comfortable if the patient gets a little bit of relief before they go to the bathroom. Then it's not quite so urgent and they can manage to get there without having an accident. Some of the clinical reasons why they would use a single contrast enema would be fistulas, which are little holes, basically, little tubes that connect parts that shouldn't be connected. So, for example, you might have a fistula from the rectum that goes out through the gluteus maximus out of the patient's body. So that little tube from the rectum to the outside of the body is called a fistula. And patients who have Crohn's disease sometimes have those things happen. Acute appendicitis, diverticulitis, volvulus, I have to say I'm not sure what that is, but I will find out and put it on Blackboard. Colon anatomy, if they just want to see filling or filling defects, they might just use single contrast. Or the age of the patient, or someone who's extremely debilitated, they just may not be able to tolerate a double contrast or barium enema with air. It's a little harder on you when your colon is inflated like that. These are two empty enema bags. The one on the left is for single contrast, and the one on the right is double contrast. And you can see there's a little extra tube to put air into the colon. There's one for the balloon and one for the air into the colon. Important patient concerns. They need to take slow, deep breaths. It's a good instruction for the patients during tipping and throughout the exam. If they can relax their muscles to reduce their pressure in their abdomen, it's a lot easier on them. Deep breathing helps to prevent spasms in the colon. If they start cramping up during the exam, it's really, really much more painful for them, and it's very difficult to complete the procedure. If it's too painful and the cramping is just not easing up, then they can't relax enough to get the whole enema done. And when you think about what they went through to get the prep all finished and to have to come back another day because they had too much cramping, it's better to help them figure out how to breathe through it and help them relax to get the procedure done. Considerations. Thankfully, the volume of barium, how much barium they use and put in, has been decreasing over the years, which is good. Sometimes patients with megacolons could use up to 2 bags of barium, and that would just be so uncomfortable for them. So communication with them, of course, is always key for their cooperation. And as I said before, if there's a perforation suspected in the bowel, then water-soluble compounds only. Barium is naturally hygroscopic, which means dehydrating. It's going to leach fluid out of your system, and that can create the barium to solidify into the bowel before they can get rid of all of it. So you're going to have a lot of hard, chalky barium in there that turns into cement if the patient doesn't follow up and drink plenty of water post-procedure. So you need to explain to them how important it is to increase their fluid and their dietary fiber over the next few days, and tell them that their stools are going to be a different color. They're going to be black, white, or gray until the barium is out of their system. It might take several days, but they need to continue drinking plenty of water throughout and increase their fiber intake. And that way they won't be frightened when they see that, you know, there's still quite a lot of barium that comes out post-exam. Colostomy patients. Patients with a colostomy are typically quite independent with their condition, and they can help you a lot in how to manage the colostomy. So when they have a colostomy, sometimes they're going to be checking to make sure that the colostomy is working, that the surgery that was done is healing. So you may do the upper part of the bowel with contrast through the colostomy, and then you may do a second one where you go in through the rectum and put contrast in that way. So they're going to check and see that there aren't any leaks, and maybe see if it's time to reconnect the bowel and close up the ostomy. So there's a lot of reasons why they may do this type of an exam. It's possible the patient had colon cancer, so they're having their annual checkup. They'll always have that colostomy. So they're very used to working with it, and ask them to help you get it all set up. And you may just look at the upper part of the colon. They may not have a lower part. A lupogram is a similar study, but what happens is the patient doesn't have a bladder, so they've used a portion of the small and large bowel and connected it to form a substitute bladder where, so the ureters then drain into that instead of into a bladder. So you will sometimes do a lupogram and check and make sure that that's functioning properly as well. And that would be an ostomy also from your stoma in the abdomen. So basically the procedures we've touched on are all non-aseptic examinations of the gastrointestinal tract. Become familiar with the equipment and the supplies you need to use for these procedures, and work as a team with other staff. Know what your responsibilities are, as well as how to keep the patient safe from infections by using gloves and washing your hands. Learn how to use the suction devices for your patient's safety. Enemas are non-aseptic procedures, but they should be clean procedures. You don't want to introduce any microbes at all into them because you dropped the tip on the floor and didn't change it. Don't do that. All the contrasts are dehydrating, whether they are water soluble or barium. They're all dehydrating, so you need to make sure to give the patient specific instructions about hydrating after the procedure so they don't end up with that cement in their bowels. Work with your colostomy patients because they can help you, and they're familiar with how their whole system works. Next year you'll get all your fluoro studies, so you'll learn how to do all of these procedures in class. But for now, start looking around for the urinals, the bedpans, and figuring out where everything is and how to help your patients best, and keeping everything clean.